네, good afternoon.
Hello, ladies and gentlemen. I am Hyojin Shin from Seoul National University Bundang Hospital. Today, I will present about
And the sixth Korea. And the seventh topic is the long-term outcomes of laparoscopic versus open liver resection for combined HCC cholangiocarcinoma. Korea. And the seventh topic is the long-term outcomes of laparoscopic versus open liver resection for combined HCC cholangiocarcinoma. Korea. And the seventh topic is the long-term outcomes of laparoscopic versus open liver resection for combined HCC cholangiocarcinoma. And the seventh topic is the long-term outcomes of laparoscopic versus open liver resection for combined HCC cholangiocarcinoma. And the seventh topic is the long-term outcomes of laparoscopic versus open liver resection for combined HCC.
Hello, ladies and gentlemen. I am Hyojin Shin from Seoul National University Bundang Hospital. Today, I will present about routine application of laparoscopic surgery for hepatocellular carcinoma located in the anterolateral segments of the liver with analysis of open conversion cases. I have no conflict of interest. In 2008, the first international consensus meetings on laparoscopic liver resection concluded that laparoscopic left lateral sectionectomy and laparoscopic minor liver resection, especially for tumors located in the anterolateral segments, should be considered standard practice. And they suggested indications for laparoscopic liver resection as solitary lesions less than 5 centimeters and located in the peripheral liver segments 2 to 6. Laparoscopic liver resection has shown better perioperative outcomes and comparable oncologic outcomes compared with open liver resection. Currently, there is no absolute contraindication for laparoscopic liver resection. However, unplanned open conversion is sometimes inevitable during laparoscopic surgery. Therefore, in this study, we aim to compare the perioperative and short-term oncologic outcome of laparoscopic anterolateral liver resection and open conversion anterolateral liver resection. And we also aim to investigate the possible risk factors for open conversion. We performed retrospective analysis of 374 patients who underwent liver resection for HCC located in anterolateral segments of the liver, which is defined as segments 2, 3, 4, 5, and 6. The study was performed between January 2004 and October 2018 at Seoul National University Bundang Hospital. The selection criteria for laparoscopic liver resection was based on the Louisville statement, but as surgical experience accumulates and laparoscopic devices have been developed, there is no absolute contraindication for laparoscopic liver resection if R0 resection is anticipated. Now, I would like to move on to the results of the study. Total of 374 patients underwent liver resection for HCC located in anterolateral segments. 62 patients underwent planned open anterolateral liver resection. 312 patients, we initially planned laparoscopic liver resection, and among them 299 patients successfully underwent laparoscopic anterolateral liver resection. And in 13 patients, the surgery was converted to open surgery with a conversion rate of 4.17%. First, we compared laparoscopic anterolateral liver resection and open conversion anterolateral liver resection. Table 1 shows preoperative characteristics, and there was no significant difference of demographic factors. Mean tumor size was 2.8 centimeters in laparoscopic group and 4.1 centimeters in open conversion group. Other organ invasion was more frequent in open conversion group. Table 2 shows perioperative outcomes. Here we can see operative time, EBL, postoperative complication rate, and postoperative hospital stay is significantly longer or higher in open conversion group. Table 3 shows pathologic and short-term oncologic outcomes. Compared to laparoscopy group, open conversion group showed less R0 resection rate and importantly, higher early recurrence rate within 1 year. Table 4 shows the cause of open conversion cases. Bleeding was the most common cause, followed by adhesion, tumor location, and oncologic concern. For the next step, we compared open conversion group with planned open anterolateral liver resection group. Table 5 shows preoperative characteristics, and there was no significant difference in demographic factors, tumor size, and other organ invasion. However, case of multiple tumor was more frequent in open conversion group than in planned open group. Table 6 shows perioperative outcomes. Open conversion group was associated with longer operation time and more EBL compared with open group. There was no significant difference in pathologic outcome and oncologic outcome between open conversion group and open group. In conclusion, open conversion anterolateral liver resection was associated with poor perioperative outcome and higher recurrence rate compared with laparoscopic anterolateral liver resection. Moreover, open conversion anterolateral liver resection showed poorer perioperative outcomes compared with planned open anterolateral liver resection. The possible risk factors for open conversion was analyzed as bigger tumor size, multiple tumor, and other organ invasion. Therefore, planned open liver resection should be recommended in the case of patients with risk factors for open conversion. Thank you for your attention.
Thank you. I'm really honored to be given an opportunity to present my talk here in KSCLS 2020 in the era of COVID-19. Today I'd like to talk about pure laparoscopic versus open right hepatectomy in live liver donors, a propensity score matched analysis. I have nothing to disclose. Regarding hepatectomy in donor, the first case of pure laparoscopic donor left lateral sectionectomy was reported in 2002, which is relatively recent period. As you can see in the review article in 2018, there are still not many cases of pure laparoscopic left lateral sectionectomy and left hepatectomy in donor. It is even more in right hepatectomy, known to be the most difficult procedure. Seoul National University Hospital started the pure laparoscopic donor hepatectomy program in November 2015, and recently about 85% to 90% of donor hepatectomies, mainly right hepatectomies, are performed under pure laparoscopic technique without any selection criteria. By June 2019, we had performed more than 300 cases of pure laparoscopic donor right hepatectomy. The aim of the study was to present the safety and feasibility of pure laparoscopic donor right hepatectomy compared with that of conventional donor right hepatectomy. Between January 2010 and September 2018, 894 donors underwent right hepatectomy for living donor liver transplantation at Seoul National University Hospital. Donors who underwent hepatectomy other than right hepatectomy and laparoscopic assisted hepatectomy were excluded. Considering that pure laparoscopic donor hepatectomy program was started in November 2015, conventional donor right hepatectomy after November 2015 were excluded. After accumulation of case and experience and standardization of the procedure, the pure laparoscopic approach was used without any selection criteria from March 2016. To minimize selection bias, donors who underwent pure laparoscopic donor right hepatectomy between November 2015 and February 2016 were additionally excluded. To correct selection biases and confounding factors, propensity score matching was performed at a 1:1 ratio. After matching, 198 donors were included in each group. Before matching, the proportion of female donor BMI, proportion of graft including the middle hepatic vein, recipient BMI, MELD score, proportion of ABO incompatibility were higher, and the recipient was older in pure laparoscopic donor right hepatectomy group. However, after matching, there were no significant differences between the two groups regarding the 9 factors of donors and the counter recipient's baseline characteristics. This table summarizes the operative outcomes of donor. The operative time, time to remove the liver, and the warm ischemic time, defined as time to start when the right hepatic artery was ligated, and to time to remove the liver, were significantly longer in pure laparoscopic donor right hepatectomy group. No donors required intraoperative transfusion. Delta hemoglobin percentage was significantly lower in pure laparoscopic donor right hepatectomy group. Postoperative peak total bilirubin, AST, and ALT, and delta bilirubin percentage, delta AST percentage, and delta ALT percentage were significantly higher in pure laparoscopic donor right hepatectomy group. The duration of hospital stay was significantly shorter in pure laparoscopic donor right hepatectomy group. There was fewer grade 1 complication based on the Clavian-Dindo classification in pure laparoscopic donor right hepatectomy group, but there was no statistically significant difference between the two groups regarding the rate of complication more than grade 2. This table summarizes the operative outcomes of recipient. The duration of hospital stay and the rate of early major complication, defined as complication more than grade 3 occurring within 30 days after LDLT, were similar between the two groups. However, early biliary complication itself was more likely to happen in pure laparoscopic donor right hepatectomy group. Although not statistically significant, there was a tendency of higher rate of late major complication, defined as complication more than grade 3 occurring later than 30 days after LDLT, in pure laparoscopic donor right hepatectomy group. Specifically, the rate of late biliary complication requiring intervention or surgery was significantly much higher in pure laparoscopic donor right hepatectomy group. Considering higher rate of biliary complication, detailed results of bile duct are described in this table. Percentage of expected multiple bile duct openings from preoperative MRCP was similar between conventional donor right hepatectomy group and pure laparoscopic donor right hepatectomy group. Trifurcation of bile duct was recorded as multiple and short right bile duct stump was recorded as single. Although the chance of getting multiple bile duct openings at the graft appears to be higher in pure laparoscopic donor right hepatectomy group, there was no statistically significant difference between the two groups. A double barrel bile duct opening was regarded as multiple bile duct openings. Chance of getting separate bile duct openings and ratio of multiple bile duct anastomosis were similar between the two groups. However, chance of getting multiple bile duct openings in donors whose preoperative MRCP showed single bile duct opening was significantly higher in pure laparoscopic donor right hepatectomy group. Duct-to-duct anastomosis was routinely performed unless the quality of recipient bile duct was bad for reconstruction. The rate of hepaticojejunostomy was similar between the two groups. There was no significant difference in recipient overall survival and graft survival between the two groups. Results from the present study indicated that pure laparoscopic donor right hepatectomy is a feasible option in experienced LDLT living donor liver transplantation centers. However, further studies should be made to confirm the safety of the recipients, especially in bile duct, and to propose a more secure and effective protocol at donor and recipient operation. Thank you for your attention.
Hi, my name is Jeong from Gyeongsang University Medical Center. My topic is long-term surgical outcomes in patients with hepatocellular carcinoma undergoing laparoscopy versus open resection. The use of laparoscopy liver resection for hepatocellular carcinoma has increased steadily, and several studies suggested that laparoscopy method may be safely performed even in selected advanced cirrhotic patients. However, there is a lack of high-level evidence from randomized controlled trials or well-designed propensity matching studies with a sufficient sample size. Well-designed comparative studies on the use of laparoscopy versus open liver resection for hepatocellular carcinoma are still required. Our study aimed to compare the feasibility and safety of laparoscopy and open surgeries in patients with hepatocellular carcinoma in terms of perioperative and postoperative outcomes, and long-term oncological outcomes. The study was conducted between November 2009 and December 2018, and this was retrospective and propensity score matching study participated in following two tertiary centers. Total 168 patients were enrolled. 58 patients who underwent laparoscopic surgery were individually matching to patients who underwent open surgery in a 1:1 ratio. The study used propensity score matching in terms of baseline characteristics, including sex, age, BMI, original liver disease, child class, ASA score, and preoperative treatment modality for HCC. The main outcome was overall survival rate, and secondary outcomes were overall morbidity, length of hospital stay, and the overall recurrent rate. This table shows patient demographics before matching. There was a significant difference in sex and preoperative treatment modality for managing HCC between the laparoscopic and open liver resection group. There was more men in the open surgery and more patients in the laparoscopic group who underwent transarterial chemoembolization and radiofrequent ablation for managing HCC before the operation. Sometimes laparoscopic approach may be the second treatment option for patients who underwent TACE and/or RFA for primary treatment of HCC for some reasons. After propensity score matching, there was no significant difference in age, sex, BMI, underlying liver disease, child class, ASA classification, preoperative tumor marker levels, and preoperative treatment modality for managing HCC between the laparoscopic group and open group. This table summarizes the intraoperative outcomes of the two groups. There were no difference in operation time, transfusion, range of resection, type of resection. This table shows the pathological characteristics of the two groups. There was no difference in tumor size, capsule invasion, lymphovascular invasion, portion of liver cirrhosis, Anderson and Steiner grade, and modified UICG staging between the two groups. There was a significant difference in the tumor pre-margin. One of the reasons could be that more non-anatomical resection, such as tumorectomy, were performed in the laparoscopic group. However, there was no difference in the proportion of tumor-positive margin rate. This table summarized the postoperative morbidity of the two groups. There was a significant difference in the length of hospital day. Laparoscopic group had a shorter hospital day than open group, and there was no significant difference in overall morbidity with Caribbean Dindo 3A and above, mortality within 90 days, readmission rate, and recurrence pattern between the two groups. There was only one mortality within 90 days. While in the intensive care unit, he developed ischemic liver damage and died due to postoperative liver failure. This table shows the long-term follow-up and oncology outcomes of the two groups. After surgery, 34 patients occurred recurrence, and there was no difference of rate in the two groups. There was no significant difference in the overall survival rate or disease-free survival rate. Our study is one of the largest-scale comparative propensity score matching studies using age, sex, BMI, the origin of liver cirrhosis, child class, ASA classification, preoperative tumor markers, and preoperative treatment modality. Our results suggest that patients who underwent laparoscopic approach had similar morbidities associated with the procedure compared to those who underwent open surgery. In conclusion, laparoscopic liver resection has no disadvantage in terms of overall survival rate, postoperative morbidity, perioperative outcomes, and long-term follow-up and oncological outcomes. This retrospective and propensity score matching study suggested that laparoscopic liver resection can be safely performed for hepatocellular carcinoma with acceptable short-term and long-term outcomes compared with open liver resection. Thank you for listening.
Hello everyone, greetings from India. I am Dr. Shraddha Patkar from Tata Memorial Hospital, Mumbai, India, and I will be presenting our experience with cholangiocarcinoma at a tertiary care center. I have no conflict of interest to declare. As we all know, cholangiocarcinoma is a disease with aggressive tumor biology and poor prognosis. Treatment options are limited. The surgery remains the best option for cure. The resectability rates are often quite low. Coming to an Indian scenario, it is a rare disease as compared to its counterpart, the gallbladder cancer, often resulting in a diagnostic dilemma. Most patients present in advanced stage, precluding curative treatment options, mainly due to socioeconomic factors and lack of awareness leading to delayed referrals to tertiary care center. There is paucity of data from India on this subject and no major studies have been published till date. According to Globocan 2018, biliary tract cancer ranks 13th in age standardized incidence rate as well as disease-adjusted life years. The aim of the study was to evaluate the clinical profile of cholangiocarcinoma patients presenting to our institution. It was a retrospective study of all patients with cholangiocarcinoma who were registered in Tata Memorial Hospital over a 4-year period from 2012 to 2016. As evident by this graph, there has been a steady increase in the number of cases, and in 2016 it accounted for 28% of all liver tumors. Out of the 726 patients registered, majority of the patients were of perihilar cholangiocarcinoma, more than 50%. This was closely followed by intrahepatic cholangiocarcinoma, which accounted for 40% of the patients. Gallbladder cancer and other diseases accounted for the rest. An interesting fact is that after the first visit, around 4% of the patients defaulted, most commonly due to poor PS, cholangitis, or loss to follow-up. 17% patients could not be offered any cancer-directed therapy upfront or within 30 days, most commonly again due to poor performance status, advanced disease, or a combination of the above two factors. Study of demographics revealed that the age of presentation was most commonly in the sex decade with an equal sex distribution. Pain was the most common symptom in intrahepatic cholangiocarcinoma, whereas it was jaundice in perihilers. The median duration of symptoms prior to presentation was around 2 months, highlighting a delay in reaching the tertiary care center for treatment. Approximately 70% of the intrahepatic cholangiocarcinomas were metastatic at presentation, whereas 50% of the perihilar cholangiocarcinomas were found to be localized. However, a significant portion of the perihilar cholangiocarcinoma had a higher level of obstruction on imaging, again obviating curative treatment options. Over 3/4 of patients of perihilar cholangiocarcinoma needed some sort of biliary drainage. A percutaneous transhepatic biliary drainage was the most common route which was utilized. A point of mention is that 22% of patients required multiple interventions, indicating complex blocks and hence the locally advanced nature of the disease. Most patients of intrahepatic cholangiocarcinoma being metastatic at presentation were offered chemotherapy as the primary treatment modality, whereas the perihilar cholangiocarcinomas were first managed by biliary drainage followed by reassessment for a possible resection. Around 36% of the patients could not take the planned treatment, and loss to follow-up was the most common cause of not doing so. Of the 73% of intrahepatic cholangiocarcinomas planned for surgery, 35 would not undergo re-exploration for the reasons mentioned in the chart. Of the 38 patients who underwent surgery, 8 were inoperable due to distant metastasis in 6 and advanced nodal disease in 2. Ultimately, 30 patients ended up having a curative resection. Coming to the perihilar cholangiocarcinomas of the 130 patients, no surgery could be offered to 73 patients due to loss to follow-up or disease progression. 57 patients underwent exploration, of which 20 were inoperable due to metastatic disease or locally advanced nature. Ultimately, 36 patients ended up having a curative R0 resection. The surgical details are elaborated in the table. The perioperative morbidity was 25% with a mortality of less than 5. To summarize, 70% of intrahepatic cholangiocarcinoma are metastatic at presentation. 29% could not take the offered treatment, with loss to follow-up being the most common cause. Out of the 73 patients who were deemed resectable, 38 underwent exploration and 30 had a curative resection, with an overall resectability rate of 11%. For the perihilar cholangiocarcinomas, 25% of the patients were metastatic at presentation. 75% required biliary drainage for jaundice. 41.3% patients did not take the offered treatment, mainly due to loss to follow-up. 130 patients had resectable disease, of which 57 went under exploration and 36 were resectable, thus resulting in an overall resectability rate of 10%. To conclude, in India, majority of the cholangiocarcinoma patients present at an advanced stage or in a poor general condition to be deemed fit to receive any sort of cancer-directed treatment and or all default during workup. Although surgery remains the most effective treatment, only 10% cases could ultimately undergo curative resection. Awareness and early referral with centralization only can help in detecting this disease at a stage where treatment can offer a meaningful survival. Thank you for your kind attention.
Today I'm going to present you that the result of 52 consecutive robotic living donor right hepatectomy compared with the open and laparoscopic assisted donor hepatectomy. I have no COI disclosure. The first robotic living donor right hepatectomy was reported in 2012. The operative time was 8 hours and the patient discharged on the post-operative day 8th. After that, in 2016, Taiwan group reported 13 consecutive cases of robotic living donor right hepatectomy, and perioperative outcomes were comparable to open group. Our center started robotic liver resection from 2008. We reported favorable outcomes in 30 cases, including 20 major hepatectomy in 2012. Our experience of robotic liver resection has expanded into anatomical liver resection in the right liver using extrahepatic Gleasonian approach, and we reported favorable perioperative outcomes in 2016. Based on our previous experiences, we took a new stage of minimally invasive procedure around 2016. We slowly move on to the hybrid procedure, which is liver mobilization by laparoscopic first, and the other procedures under upper midline incision instead of a conventional open donor hepatectomy. And we started a pure minimally invasive procedure as robotic donor hepatectomy from April 2016. So in this present study, the clinical and perioperative outcomes of 52 consecutive robotic donor hepatectomy were compared with 62 cases of conventional open donor right hepatectomy and 118 cases of laparoscopic assisted donor right hepatectomy. Here are the clinical characteristics in donors. The mean estimated preoperative total liver volume and mean graft volume in robot group were significantly different from laparoscopic assisted group. Although robot group had the longest mean total operative time among the three groups, and it also had the lowest mean estimated blood loss. Regarding comprehensive complication index, which is a CCI, there was no significant difference between the three groups. The indication for robotic surgery were first extended to donors with a large graft, followed by the presence of inferior right hepatic vein and the variation of bilots. Among at least 30 cases, totally 12 cases were more than at least one positive for extended criteria. As the periods proceeded, the total operative time and consult time and the mobilization time gradually decreased. However, hilar dissection time and the parenchymal dissection time of fourth period were longer than third period. Warm ischemic time also significantly increased over the study periods. Maybe this is related to the extension of criteria, which were the complicated cases. To compare donor wound satisfaction, we used a questionnaire. The response rate was 82% of robot group and 66% for laparoscopic assisted group. The robot group had a significantly higher body image scores than laparoscopic assisted group. The cosmetic score of robot group was also significantly higher than laparoscopic assisted group. However, more than 60% of donors in robot group felt dullness or numbness at the wound site, which was significantly higher than the laparoscopic assisted group. The robot group had a significantly higher peak serum ST and ALT levels. However, the robot group had a shorter duration to INR normalization. On postoperative days 1 and 3, AST and ALT levels of the robot group were significantly higher than two groups. The peak ALT level had a negative correlation with the cumulative case number. Regarding recipient's outcomes, the donor's father was the most common recipient. MEL score was similar between the robot and the conventional open groups and were significantly lower than the laparoscopic assisted group. And there were one case of a 30-day mortality in each group. Regarding postoperative complications, biliary problems were the most common major complication, and two graft subcapsular hematomas occurred in the laparoscopic assisted group. There were no significant differences in CCI. After propensity score matching, 19 patients from each group were analyzed. Regarding perioperative outcomes, analysis of donors, hospital stay, and total operative time and estimated blood loss were significantly different. There were no differences in the postoperative surgical complications, including CCI. In comparison of recipients' perioperative outcomes revealed no difference between the three groups in terms of a complication grade or CCI. This is a conclusion. Robotic living donor right hepatectomy resulting in less blood loss compared with the conventional open method, and a similar postoperative complication rates to conventional open and laparoscopic assisted hepatectomy. And robotic living donor right hepatectomy provided better body image and cosmetic results compared with the laparoscopic assisted group. And the robot living donor right hepatectomy is feasible and safe when performed by the surgeons who experienced with both robotic and open hepatectomy. Thank you for listening.
Hello, ladies and gentlemen. My name is Jeong Kim. Today, I'll present my work on improved outcomes of major laparoscopic liver resection for hepatocellular carcinoma. I have no personal or financial interest to declare. These are the contents of my presentation. I'll begin with the background and introduction to the study. HCC is fourth most common cause of cancer-related death worldwide. Surgical resection is considered as standard treatment if indicated. For the liver resection, both laparoscopic and open resection is widely performed. In the second consensus meeting held in Morioka, Japan, minor laparoscopic resection is now considered as standard practice. However, unlike minor resection, major resection is still challenging due to difficulty in bleeding control and high technical demands. In 2012, our center adapted advanced techniques including the use of intercostal chokers, Pringle maneuver, and semi-lateral position of patients. And these adaptations enabled us to perform major laparoscopic resection more extensively. Hence, we sought to compare the perioperative outcomes of major resection for HCC before and after the adaptation of technological improvements. I would like to move on to the materials and methods. In selecting patients, we retrospectively reviewed the records of 141 patients who underwent major laparoscopic resection for HCC between January 2004 to September 2018. And among them, 32 open conversion cases were excluded for the analysis. The patients were divided into two groups, Group 1 and Group 2, who underwent major laparoscopic resection before and after 2012 when advanced techniques were adapted. Additionally, we compared these patients, including open conversion cases, with those who underwent major open liver resection during the same period. We used the Brisbane 2000 terminology to define liver resection. The extent of resection was defined as major or minor according to the number of resected segments. Major if more than 3 segments were resected. Right anterior and right posterior sectionectomy were also considered as major resection since these procedures are challenging to perform both by open or laparoscopically. Laparoscopic resection was not considered for the tumor size greater than 5 cm in diameter and tumor invading or adjacent to main portal pedicle or IVC. We used flexible laparoscope and intraoperative ultrasound to identify the exact tumor locations and check for the resection margin. The Pringles maneuver was performed by clamping the hepatoduodenal ligaments, and each clamping time was restricted to maximum 15 minutes to avoid ischemic damages to liver parenchyma. For the resection of the parenchyma, ultrasonic shares and CLUSA was used. Now, I would like to move on to the results of the study. The following table shows preoperative characteristics of analyzed patients. Here, we can see operation time, blood loss, transfusion rate is less in group 2. However, we could not find any difference in post-operative complication rate. The following table demonstrates pathologic and post-operative outcomes of the patients. Hospital stay was significantly less in group 2. However, there was one mortality case in the same group. This table demonstrates the comparison of open and laparoscopic resection. Tumor size was greater in open resection group. Transfusion rate, complication rate, hospital stay was significantly less in laparoscopic resection group. The following slides summarizes the result. Now, I would like to move on to the discussion of the current study. Although major resection was considered challenging due to the risk of hemorrhage and difficulty in massive bleeding control, technical improvements are enabling us to perform laparoscopic resection more extensively. Intraoperative ultrasound and flexible scope offered better visualization of the location of the tumor. To further improve the surgical outcome, we adapted several improvements: the use of intercostal chokers, Pringle maneuver, and placing patients to semi-lateral position. First, the use of intercostal chokers helped better visualization of the tumor located at unfavorable locations. Second, utilization of Pringle maneuver further allowed better bleeding control and less transfusion rate. Lastly, by placing patients in semi-lateral position, visualization of liver hilum and exposure of the right posterior segments became possible. In conclusion, development of surgical techniques and accumulation of the experiences have gradually improved the outcomes of laparoscopic operation for major liver resection. However, it must be performed cautiously by an experienced surgical team at highly specialized centers. Thank you for your attention.
Good afternoon, ladies and gentlemen. It's my honor to have a chance to present about long-term outcome of laparoscopic process open liver resection for combined hepatocellular cholangiocarcinoma. There is no COI. Combined hepatocellular cholangiocarcinoma is a rare primary hepatic neoplasm. Liver resection is still the preferred treatment choice. With the advancement of minimal invasive techniques, laparoscopic liver resection is now a possible option for patients with resectable combined HCC and CCC. However, there is no published study analyzing the feasibility of laparoscopic liver resection for combined HCC and CCC. This study aims to compare the long-term survival and post-operative complication of laparoscopic liver resection with open liver resection in combined HCC and CCC. Patients who underwent liver resection for combined HCC from 2004 to 2015 were enrolled. Those who received palliative surgery and who had a follow-up of less than 3 years were excluded. Medical records of these patients were retrospectively reviewed. Primary end outcome was 3 years disease-free survival and 3 years overall survival. Total 40 patients were enrolled, with 23 in the laparoscopic group and 17 in open group. Mean age was 60 years in lab group, 61 years in open groups. In both groups, most of patients did not receive any pre-treatment before surgery. 14 patients in lab group had liver cirrhosis at the time of operation. 14 patients had cirrhosis in open group. Tumor location was classified as unfavorable in 9 patients in lab group, 8 patients in open group. There was no statistical difference in mean tumor size between lab and open group. There was more patients in multiple nodule in open group than laparoscopic groups. But there is no statistical difference. The proportion of patients with underwent major hepatectomy was similar in both groups. And there was no difference in proportion of patients who underwent lymph node dissection. This table showed the pathologic and operative outcome of both groups. There was no statistical difference in pathologic T stage and N stage. Mean operation time was 326 in the leg group and 313 minutes in open group. Estimated blood loss was higher in open group, but there is no statistical difference. Hospital stay was shorter in leg groups. It showed the statistical significance. P-value was 0.01. There was also fewer number of patients with early complication in lab groups compared to the open groups. Mean follow-up was 38 months in leg group and 43 months in open group. 4 patients from leg group changed to open procedure, open conversion during the surgery. The reason for this conversion was large tumor size and diaphragm invasion and not enough the surgical margin. This graph shows the 3 years overall survival and disease-free survival. 3-year overall survival was 81.6% in red group and 72.1% in open group. 3-year disease-free was 63% in red group and 48% in open group. But there was no statistical difference in between two groups. For 3 years overall survival, there is no factors that show the significance in univariate and multivariate analysis. For 3 years disease-free survival, major hepatectomy showed the marginal significance in univariate analysis. The multivariate analysis was performed. The major resection did not show any independence associated with this 3 years disease-free survival. There was 11 cases of recurrence, a recurrence in the remaining liver, 2 cases metastasis in regional lymph node, 3 cases recurrence happened in the distant lymph node, 1 recurrence in the lung. There is some limitation in this study. First, sample size is too small. Second, we did not perform lymph node dissection for the most of cases, so we don't know the exact meaning of lymph node dissection for combined HCC and CCC. Ladies and gentlemen, I'd like to conclude this study. Laparoscopic liver resection for combined HCC and CCC is technically feasible and safe. It providing short-term benefit without affecting long-term survival. However, we need a large-scale multi-center data collection and prospective study. Thank you.
Thank you for kind introduction, Chairman. My presentation is about difficulty scoring system for pure laparoscopic donor right hemipatectomy. Difficulty score evaluation was introduced by laparoscopic liver surgery group based on the tumor site, location, major vascular invasion, and extent of the surgery. This scoring system is suitable for laparoscopic liver surgery for malignancy like HCC or cholangiocarcinoma. But the donor who planned the laparoscopic donor surgery, there was no tumor, no cirrhosis, and they are usually underwent right or left hemipatectomy. Therefore, if we use the current difficulty scoring system, the difficulty of every donor was the same. But each surgery has different difficulty, and it is not well known which factor affects the difficulty in the laparoscopic donor hepatectomy. The aim of the study is to evaluate which factor affects the surgical difficulty in pure laparoscopic donor right hemipatectomy, and to make a new difficulty score system for laparoscopic donor hepatectomy and validate its utility. From January 2019 to December 2019, 93 donors were underwent pure 3D laparoscopic right hemipatectomy. We describe difficulty score based on the several factors. Difficulty score composed of 5 rated systems. Donor factor composed anatomic variation, small abdominal cavity, huge liver and half liver. Other factors composed the absence of main scopist, first assistant, scrum nurse, and device problems. And we analyzed the correlation between difficulty score with the operative time, estimated blood loss, and post-operative complications. This slide shows the definition of the factor composed difficulty score. The body cavity is difficult to evaluate by preoperative images, so we evaluate after inflating the air into the abdominal cavity through the umbilical trocar. And anatomical variation was confirmed by dynamic CT and pre-morphine MRI in the preoperative period. The huge liver was defined as a case when the estimated graft volume was more than 700 cc in the 3D volumetry. liver density was defined that the donor has a sticky and fibrotic tissue. We can evaluate this during the parenchymal dissection with the CUSA or energy device. And F1 status in the preoperative fibroscan was also defined as a hard liver. And non-donor factor was the absence of the main scopist, first assistant, or scrum nurse, and the device problem. The main member composed the laparoscopic donor hepatectomy have already has more than 100 cases of pure laparoscopic donor hepatectomy. And basic demographic findings such as age, gender, BMI was entered as a covariate. Difficulty score evaluation was performed by the surgeon, scopist, first assistant, and scrum nurse in the immediate postoperative period. The grade 1 means very easy. Number 2 means little harder than usual. 3 means moderate difficult. 4 means very difficult. 5 means too difficult as much as we consider the open conversion during the surgery. We described the above factor and difficulty score in the operative record. The total 93 cases of the donor who underwent pure laparoscopic donor right hepatectomy. Table 1 shows perioperative finding along with the difficulty score. As the difficulty grade increases, the donor has more variation of the bile duct, small cavity, and a huge liver. And this slide shows postoperative findings along with the difficulty score. As the difficulty score increased, the operative time and estimated blood loss was significantly increased, but there was no correlation between the difficulty score with the complication rate. Total complication rate was 3.2%, and there was no open conversion nor perioperative transfusion. The person who received the score 1 to 2 was defined as an easy case, and the person who received the score 3 to 5 was defined as a difficult case. As the correlation analysis, the variation of the bile duct, small cavity, and huge liver proportion was significant different between two groups. In the univariate analysis, a variation of the bile duct, small cavity, and huge liver were risk factor of the difficulty, and other factor did not show any significant difference. The curious thing is that in the non-donor factor, the absence of the one person among the main member did not significantly increase the surgical difficulty, but the difficulty increased when the two or more members were absent. Variation of the bile duct, hepatic vein, and small cavity usually will affect the difficulty score of the pure laparoscopic donor right hepatectomy. This new difficulty scoring system is well correlated with operative time and estimated blood loss. Complication rate was only 3.2%. The member of the surgery also affect the difficulty score. When the main member was replaced more than half of the first line of member, difficulty score significantly increased. Previous difficulty score system is now applicable to laparoscopic donor hepatectomy. This new difficulty score is well correlated with operative time and estimated blood loss and is better than current difficulty score system in the laparoscopic donor hepatectomy. This difficulty score could be used to screen the easy case, the initial period of center that are willing to start laparoscopic donor hepatectomy. And for the successful setting up the laparoscopic donor hepatectomy, the teamwork approach of expert members are also important. Thank you for your kind attention.
Now, thank you for all audience. And I have one question to Dr. Parker. Are you
Yes.
hearing?
Yes, good morning.
Yeah, good afternoon in Korea. Thank you for joining.
Yeah, good afternoon. Thank you, thank you.
Yeah, thank you. Yeah, good afternoon in Korea. Thank you for joining. Thank you for joining.
Yeah.
I have one question, Dr. Parker.
Yes.
Yeah,
Yes.
performed chemotherapy in patients with all intrahepatic and perihilar cholangiocarcinoma, even the lymph node metastasis, no lymph node metastasis cases.
No, we don't give chemotherapy to all patients. Only patients who on imaging appear to have nodal metastasis, that also intrahepatic cholangiocarcinomas, we give chemotherapy, not for perihilar cholangiocarcinoma.
Only intrahepatic cholangiocarcinoma.
Only intrahepatic. Yes, yes.
Yeah, yeah. Do you perform the lymph node dissection in the intrahepatic cholangiocarcinoma patient?
Yes,
Lymph,
yes. For all intrahepatic cholangiocarcinoma,
yeah,
complete lymph node dissection. Yes.
yeah. Okay, okay,
Yes, yes. Along with sampling naval node also.
okay. Thank you, Dr. Parker. Joined this
Thank
session.
you.
Thank you, all audience and speaker. This session will be closed, and thank you very much.
Thank you. Thank you.
See you later.